You can. Dhanraj,
Yes, sir.
you can start, and if anybody else joins, you just admit them. Okay.
Okay, sir.
Yeah, you can start the lecture.
Okay, sir. Um, Good morning, all. Today's our topic of discussion is optic nerve head differentials. Um, we are going to discuss the topic under the heading of optic atrophy, optic disc edema, optic disc hemorrhages, optic disc collateral, and congenital optic disc anomalies as a differential for the optic nerve heads. Then first we'll go for the optic atrophy. Optic atrophy, pathologically, it will be classified as ascending, descending, and the transsynaptic one. Ascending one in which the primary lesion is in the retina, optic nerve, or the choroid, and the atrophy proceeds towards the brain. It is also known as a Wallerian degeneration. Descending one, the primary lesion is the intracranial, and it proceeds towards the optic nerve, as in case of the intracranial space occupying lesion, as well as the in case of raised intracranial tension. In transsynaptic one, the phenomena by which the neurons on one side of the synapse degenerate as a consequence or of loss of neurons on the other side. It can be the congenital or the acquired retinogeniculate lesion. Ophthalmoscopically, optic atrophy, it's been classified into the 5 types: primary, secondary, consecutive. The third one is the cavernous, and fourth one is the sectoral or the partial optic atrophy. In case of the primary one, the degeneration of the optic nerve fiber and the replacement by the glial tissue will be there, and there will be without any alteration of the architecture of the optic nerve. Here you can see the optic nerve margin will be the clear one, the vessels which are emerging from the center, and there will be no any highlight bodies will be there, as well as the optic cup will be the preserved one in case of the primary optic atrophy. In case of the and the disc color will be the chalky white in case of the primary one. In case of the secondary, architecture of the optic nerve head is lost due to the degeneration of the optic nerve fibers along with the excessive proliferation of the glial tissue. This usually follows the optic disc swelling. Okay, here the color of the optic disc will usually will be the dirty white color will be there. Then perivascular sheathing will be there, and there will be the loss of the optic cup will be there, and it is replaced by the hyaline tissue, as well as the surrounding area. There will be the in case of the papilledema, there will be the patterns line. In case of the consecutive one, the diseases of the retinal vasculature, retinal ganglion cells, or the choroid will be there, and so there will be the surrounding changes will be there in case of the retina. And in case of the for example, in case of the retinitis pigmentosa, we'll get the bony speckles in the periphery, as well as the pale waxy color of the optic disc will be there. Next one comes the cavernous. It usually seen in case of the glaucomatous optic atrophy. There will be the axonal degeneration without any proliferation of the glial tissue, and the characteristic formation of the caverns, which fills the hyaluronic acid and resulting in excavation of the optic disc. Typically, it is seen in glaucomatous optic atrophy. In case of the sectoral or the partial optic atrophy, it can be there can be the temporal or the altitudinal disc pallor will be there. Commonly, it is seen in case of the toxic or the nutritional optic neuropathy. In case of the NAION, initially it presents as the optic disc followed by the sectoral disc pallor. This is just summarize the optic atrophy that is ophthalmoscopically seen. Disc appearance will be chalky white in the primary. It will be the dirty gray in color in case of the secondary, waxy pallor in case of the consecutive one, cavernous, vertically enlarged cup will be there, and in segmental or the partial optic atrophy, there will be pallor. It is seen usually temporally, or it can be seen as a sectoral one. Okay, rest all the things I had explained already. Optic next topic of discussion, that's the optic disc edema. In case of the optic disc edema, it can be the unilateral or the bilateral optic disc edema will be there. Okay, unilateral, the causes of unilateral optic disc edema most commonly is the non-arteritic ischemic anterior ischemic optic neuropathy. Next one is the optic neuritis. Third one is the central retinal vein occlusion. Next, the diabetic papillitis, neuroretinitis, ocular hypotony, and the pseudoedema. Next, and the causes for the bilateral optic disc edema, these are the papilledema, hypertension, advanced Graves' disease, diabetic papillitis, cavernous sinus thrombosis, and the Leber's hereditary optic neuritis. We'll differentiate a few of the important feature of optic neuritis, papilledema, and the ischemic neuropathy, in which the first one is the vision one. In case of the optic neuritis, there will be the rapidly progressive loss of vision will be there, and there will be the central scotoma in case of the optic neuritis. In case of the papilledema, there will be the transient obscuration of vision will be there, and on the field evaluation, we'll get the enlarged blind spot. In case of the ischemic neuropathy, there will be the altitudinal field defects will be there. Symptoms: patients will usually complain of the tender globe, pain on the movement of the eye. In case of the papilledema, patient usually complain of the headache, nausea, and the vomiting. That's the systemic complaints. And in case of the ischemic neuropathy, usually the patient will complain of headache. That too most commonly in arteritic anterior ischemic optic neuropathy only. Next is the laterality. That's again the optic neuritis and the ischemic neuropathy. These are the unilateral one, while the papilledema, it's a bilateral condition. In case of the fundus examination, we'll get the disc swelling and the flame-shaped hemorrhage, as well as cells in the posterior vitreous in case of the optic neuritis. While in case of the papilledema, we'll get only the disc swelling along with the flame-shaped hemorrhage. While in case of the ischemic neuropathy, we'll get the segmental disc edema along with the disc hemorrhages. The vision prognosis will be the in case of the optic neuritis, it returns to the normal or the functional level. In case of the papilledema, the visual prognosis will be the good, but in case of the ischemic neuropathy, the poor visual prognosis will be there. This is just one image. Can anyone just give me the spot diagnosis, or what will be the findings over there? Yeah, it's a disc edema. Okay. And in this image, okay. So here we have to differentiate between these two images. That two, first one is of the papilledema and second one is the pseudopapilledema. So what are the differentiating features between these two images? Okay, so here we'll in case of the papilledema, we'll usually get the hyperemic disc, as well as the blurring of the disc margins will be there, as well as obscuration of the vessels will be there, and as well as in addition to that, the peripapillary nerve fiber layer thinning will be there. But see, in this image, only the optic disc nerve head is elevated as compared to the margins, which are almost peripapillary. There will be the no edema will be there in case of this image, as well as there will be the no hyperemia, and the vessels which are not obscured at any level when after it emerges from the center of the disc. Okay, so this is just a pseudopapilledema. Now we'll see the few of the differentiating features. First one is the visual symptoms. As I already described, as in case of the papilledema, there will be the transient obscuration of the visual field defects will be there. But in case of the pseudopapilledema, only the transient loss of vision will be there, and visual fields will be can occur. There will be the headache in case of the papilledema, but no headache will be there in case of the pseudopapilledema. In neurological symptoms will be there in case of the papilledema, but it won't be there in case of the pseudopapilledema. Optic nerve head appearance will be the elevated hyperemic peripapillary vessel obscuration will be there, and the flame-shaped hemorrhages will be there. Okay, as well as in case of the pseudopapilledema, this elevation is confined only to the disc. Okay, in case of the papilledema, there will be the loss absent or spontaneous venous pulsation will be there, but these might be the present or the absent in case of the pseudopapilledema. Okay, and then comes the disc color. That's I already described it as a hyperemic, and in case of the pseudopapilledema, it's a yellow one. Nerve fiber layer, it's opacified in papilledema and transparent in pseudopapilledema. Large vessels are normal, as well as anomalous trifurcations and the spoke-like furcations will be there in case of the pseudopapilledema. Small vessels will be the telangiectatic. Hyaline bodies will be absent in case of the papilledema, and the nerve fiber layer hemorrhages will be the frequent one, which all absent in the case of the pseudopapilledema. And one of the important differentiating features, that's the on fluorescein angiogram, dye leakage will be there at the disc, and there will be no leakage or the late staining at the in case of the pseudopapilledema. Okay, now the important causes for the pseudopapilledema, these are the optic nerve head drusen, congenitally crowded disc, tilted disc will be there, and the optic nerve head hypoplasia. One of the important grading system of the papilledema, along with few of the photographs are there. These are the first in grade 1. There will be the grayish halo which is surrounding the disc, and it usually spares the temporal disc margin, and the radial nerve fiber striation disruptions will be there. In case of the grade 2, this halo becomes circumferential, as well as there will be the elevation of the nasal border will be there, and there will be no major vessel obscurations will be there. In case of the grade 3, see, at least one of the vessels of the disc will be obscured. One elevation of the all borders will be there, and the circumferential halo will be there in case of the grade 3. In case of the grade 4, in addition to the grade 3, there will be the obscuration of major vessels will be there, and the complete elevation of the cup will be there with a circumferential halo, which will be easily demonstrated in case on the B scan. Okay, then in case of the grade 5, there will be obscuration of the vessels all over the disc, and all other features of the grade 4 will be there. Okay, next comes the disc hemorrhages. Disc hemorrhage, it is one of the important finding that we have to usually rule out. Few of the important causes for the disc hemorrhage, these are the normal tension glaucoma progression. Here the only findings will be patient with a normal tension glaucoma will be only the disc hemorrhage, but along with that there will be the nerve fiber layer defect will be there, which is we have to look for the glaucoma field evaluation in case of the normal tension glaucoma to just rule out the progression of the glaucoma. Okay, in case of the pseudo exfoliation syndrome, there will be the disc hemorrhages, will usually get the disc hemorrhages. Then systemic uncontrolled hypertension, there will be the disc hemorrhages along with the other findings of the arterial and the venous findings will be there. In case of the diabetes, we know that diabetic papillitis, as well as other findings of the neovascularization, as well as dot blot hemorrhages and the exudates will be there. Migraine, there will be the disc hemorrhages. Vascular diseases as angina, myocardial infarction, and next one is the aspirin use. One more important finding in it, that's the disc collateral. Disc collateral, actually this is the just a collateral circulation between the retinal central retinal vein as well as the choroidal vessels. Okay, usually all these are the all these vessels will be present in normal individuals also, but in case when there is any obstruction to the central arterial vein will be there, then there will be these collateral, they will get enlarged, and they will just forms the pathway for the directly to the choroidal circulations. Okay, few of the important causes of the disc collateral, these are the central and the hemi-retinal vein occlusion, then optic nerve sheath meningioma, chronic glaucoma, and the few of the less common, these are the chronic papilledema, optic nerve head drusen, optic nerve glioma, arachnoid cyst of the optic nerve, phacomatosis, and the diabetic retinopathy. Okay, now we'll go ahead for the congenital anomalies of the disc. First one is the tilted disc. We usually get this kind of tilted disc in case of the astigmatism as well as myopic patients. Okay, so the axis of the disc, usually it is directed infero-nasally, and the disc margin is indistinct where the retinal nerve fiber layers are elevated. Peripapillary chorioretinal thinning may be marked one. Next one is the optic disc bit. Here the disc is usually of larger size, and there will be the grayish round oval pit which is of variable size, which is most commonly located temporally, but the location can be the variable one. And the glaucoma field defect will be there, which mimic the glaucoma in these patients. Next comes that's the serous macular detachment, which is the associated with the disc pit directly. Here we can see the directly there is excavation in the optic nerve head, and which is attached directly to the retinal. Here we will get the schisis like separation between the layers, and there will be the serous retinal detachment. Next comes the optic disc coloboma. There is the coloboma. Usually, there is a defect in one or more structure due to the incomplete uh, fissures, incomplete closure. The defect usually unilateral or the bilateral and occurs sporadically in otherwise the normal individual. There are the numerous systemic association of the optic disc coloboma. That's the Charge syndrome, chromosomal abnormality, golden hair syndromes. Then in each there is the focal glistening bowl shaped excavation will be there, with the inferior neuroretinal rim will be thin or the absent, and then which is the normal disc tissue which is confined to the superior wedge with a variable size depending on the severity. Okay, there may be associated or even continuous with a large chorioretinal coloboma will be there. Next comes the morning glory anomaly. It is a rare, usually unilateral or the sporadic condition with a has a variable spectrum of severity. It usually bilateral cases. There will be it is the rare, and the it may be the hereditary one. There are the few of the systemic associations will be there, in which the most important is the frontonasal dysplasia, midfacial anomalies, basal encephalocele, and the midline brain malformation, including the pituitary insufficiency. Few of the important signs, the visual acuity may be normal or the impaired to the variable extent. Large disc with a funnel shaped excavation will be there. White tuft of glial tissue which overlies the center of the disc, as well as it represents the persistent hyaloid vascular remnant, and the blood vessels which emerges from the rim of the excavation in the radial pattern like a spokes of the wheel. Then next comes the myelinated nerve fiber. Usually myelination of the ganglion cells of the axon extend beyond the cribriform plate, and it visible in the retinal examination in about 1% of the population only. And this is known as a myelinated or the medullated nerve fiber. The condition is usually congenital and the stable one. One or more whitish striation patches in the feathery like pattern. It is seen in the peripheral along the peripheral retinal vasculatures also. Next comes the optic nerve head hypoplasia, in which there is a hypoplastic optic nerve, which is the unilateral or the bilateral, and it carries the diminished number of the nerve fibers. Then the mild hypoplasia consists simply of the smaller than the normal disc. Foviola disc center distance of the 3 or the more times the disc diameter strongly suggests the hypoplasia. Further along the hypoplastic spectrum, a small gray disc is seen with a central cupping like deficiency of the neural tissue and the disc vessels emerging in the radial configuration. There are the few of the systemic association of it, that is the pituitary and hypothalamic deficits will be there. The most frequent association of it, that is the septo-optic dysplasia, or it is also known as a de Morsier syndrome. Bilateral optic nerve hypoplasia will be there. Then there will be absent septum pellucidum, corpus callosum dysgenesis will be there, and the hypopituitarism will be there. So that's it for the today's class. अरे 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 Yes, finish. So any question?
इसको ये कैसे करना ऑटो रोटेट फुल स्क्रीन
So any question? Any part of it you don't understand? So thank you all.
Hello.
Hello, sir.
Yes, Dhanraj. Finished?
Yes, sir.
Okay. I will just end the meeting. We'll discuss it later.
Okay, sir. Okay.
Yeah.